I was given an opportunity to come to Saskatchewan again. I've been here before, of course, to see the progress that has been made in the fight against HIV and AIDS. And I must say that I'm favorably impressed by the partnerships that have emerged and the progress that have been described to me. There is a long road ahead of us, and hopefully some of the stuff that I'm going to share with you is going to be of value in trying to inform in next steps. I had an opportunity to meet with your Minister of Health today, with a few of your colleagues. Dustin Duncan, and the Honorable Dustin Duncan was most impressive. I don't mind going on the record saying that I was very impressed. He left me with a sense of optimism and with the impression that he gets it and that he wants to make a difference. So, as I told him during our meeting today, I'm planning to come back rather soon and see how much more work we can do together. So, on that note, let me just move on to my presentation. I entitled this From a Hypothesis to Global Policy regarding HIV treatment and prevention. I think that what I'm going to share with you is a little bit of the history of how we run into some of these new understanding of how treatment can help us to curb the impact of HIV and AIDS regarding morbidity, mortality, and transmission. And in doing so, we now are rapidly emerging with a strategy for the global control of HIV and AIDS. This is, to put things into context, this is what the epidemic looked like as I was moving from my hometown, Buenos Aires in Argentina, to Vancouver to do a one-year fellowship that lasted for the rest of my life. I arrived in Vancouver in 1981, and as you can see here, shortly thereafter, North America was inundated with HIV and AIDS. I didn't bring it, it happened to come together. And what you see then next is that through a number of unrelated efforts, we and others were able to contribute to the discovery of the so-called triple therapy cocktail that emerged at the conference, quite coincidentally, in Vancouver in 1996, which really became the coming out party of this new novel treatment approach. We were incredibly fortunate, not that we didn't work very hard, but we were very fortunate that all of this came together in Vancouver because it gave us the opportunity to use the conference as a massive knowledge translation effort. And as a result of that, very quickly, without any additional investment, if you want, other than the drugs, of course, we had lineups of people that wanted to access what it was, this very promising new development. As a result, as you can see here, on the yellow line, death rate following the Vancouver conference started to plummet and life expectancy started to rise. My good friend, Bob Hogg, who is our senior demographer, recently updated the estimates for the estimated survival of people infected with HIV who engage promptly on antiretroviral therapy for life. For a 20-year-old person infected with HIV today who is diagnosed promptly and initiated on treatment shortly thereafter, we expect that that person is going to have a preserved longevity, preserved quality of life, and is going to make it to somewhere around 75 years old. So I tell my patients, you have to pay your taxes. In the old days, they didn't have to. And this is a good thing. Now, I'm not going to spend any time talking about treatment strategies, etc. I'm moving right along to describe for you what we uncover really while monitoring or watching the impact of our treatment program in our community. And that's highlighted in this slide, which shows for you an unprecedented and certainly unexpected decline in the number of new HIV infections that we saw immediately after we rolled out the treatment, 1996, and into the year 2000. As I will show you in a subsequent slide, By the year 2000, the number of people on treatment had stabilized, and so had stabilized the number of new infections that we were diagnosing on a yearly basis. That gave us a tip that treatment could be playing a role in decreasing the effectiveness of people who were living with HIV. The other thing that was noteworthy in this slide was the yellow line, which is the number of cases of syphilis that were occurring during that time. And so for us, it was particularly critical to see that HIV new cases were going down while actually syphilis rates were going up. That suggested that there was something that was applying differential pressure, slowing down the ability of HIV to be transmitted at a time in which risky behavioral activities were still continuing. We had our team really deploy a whole lot of resources to try to understand this, and we came up with the conclusion that in order to explain this phenomenon, treatment would have to be at least 90% effective on stopping HIV transmission. Eventually, it took us a few more years, but we were able to construct an argument that suggested that if we were to bring testing, treatment, care, and support, all of that lined up together appropriately to any given jurisdiction so that the coverage with antiretroviral therapy could reach very high levels, theoretically 100% coverage, we could actually see the end of AIDS morbidity, premature mortality, and HIV transmission. We postulated that in a paper that we published in The Lancet in 2006. This became the plenary address that I had the privilege of giving at the Toronto conference, and that started a storm, the likes I did not anticipate. The first person that I met actually was Stephen Lewis, who came to me offering his protection because he was afraid that those that didn't believe on this approach were going to get really nasty. And lo and behold, he was right. But a lot of people came to our help, and working with them, as I'll show you in the next few slides, we were able to actually demonstrate the value of the strategy and ultimately move it to the global scene. Perhaps the one person that was most influential was my premier. Premier Gordon Campbell got into the action at the time. We had lengthy conversations regarding this issue. Very quickly he understood the value, the potential value of this strategy, and he actually allocated additional resources for us, not only just to buy antiretroviral therapies, but also to increase testing and to increase support and engagement of people who were living with HIV. As you can see here, the early phase of the rollout that I mentioned earlier, 1996 to 2000, reached a stable phase or a plateau between 2000 and 2003. And then when we started the negotiations with the provincial government, you see a steady rise in the number of people on treatment that continues even today. I can therefore show you the relationship between that curve and the AIDS incidence, or the number of new AIDS cases in the province of British Columbia year after year. You see here, prior to the availability of HAART on the pink panel, a very rapid increase, as I show you for North America in my first slide. Very rapidly, AIDS cases were accumulating in British Columbia. You notice that in the mid-90s, with the entry of combination antiretroviral therapy, particularly in 1996, that curve goes down. So the HAART on the blue, the HAART era, drives AIDS numbers quite nicely down, but it didn't do the full job. We were left with the chronic sort of 200 cases per year of AIDS, because having the treatment available was not the same as being able to bring it to the people in need. And so by changing the philosophy from saying come and get it to us saying we're going to come and meet you where you are, as you heard me describe earlier in the introduction, allowed us to totally change the dynamic. And look at what happened. AIDS diagnosis virtually disappeared. Not only AIDS diagnosis virtually disappeared, but as you can see here, while mortality among people infected with HIV had gone down with the availability of HAART, you can see that only when treatment and prevention became the new policy, when we were able to bring services to the people in a facilitated way, with appropriate support, with harm reduction programs, and so on and so forth, we saw virtual control of AIDS-related mortality. In fact, about a year ago, my premier, this is my new premier, Christy Clark, who took over from Gordon Campbell, agreed after lengthy discussions with community, with stakeholders, with everybody interested, to actually formally declare the closure of the AIDS ward. Don't worry, we haven't thrown those beds away. We keep the ward. Is now dedicated to support people who are aging with HIV, who may have other medical illnesses, but this is no longer an AIDS ward. It's also develop a dual purpose, and it's supporting people with addictions, whether or not they're infected with HIV, because throughout the work that we've done with HIV, we developed a huge amount of expertise on how to work with the IDU community, and so therefore we now have a new resource for our patients, both those living a healthier life with HIV but without AIDS, or those that are at risk for HIV as a result of the substance use. This was an important moment because we made it into a sort of an international event. Michel Sidibe, the man in the middle there, is Executive Director of the United Nations AIDS Program, and he flew to Vancouver for this purpose, and that's when we came up with this new idea, some sort of a plan for the so-called AIDS-free city campaign, and that was launched late last year, and we are hoping to engage city governments to hopefully one at a time be able to achieve an AIDS-free city situation in most of the urban centers around the world. We recognize that there is AIDS and HIV outside the cities as well, but this is one way of trying to get this momentum building up. The other thing, and I was very happy to learn earlier today that this is something that we already shared with Saskatchewan, is the fact that we have virtually conquered the mother-to-child transmission or vertical transmission of HIV. And it's important to realize that while in the old days we used to talk about programs specifically designed to offer treatment to women who were pregnant, to prevent transmission, and so on and so forth, today, with treatment and prevention, by offering treatment to every single person that is infected with HIV, we really can achieve 100% control of mother-to-child transmission without the additional burden of having additional programs. So treatment really does both things for us. And when it comes to the overall number of HIV new infections that we're seeing in the province, as you can see here on the red, the more people you treat, the higher up that curve goes, the lower down the new diagnosis in the blue go, and so the more you treat, the less you diagnose, the more and more we treat, the less and less we diagnose. And today we are at an all-time low in the number of HIV diagnosed cases. We have decreased mortality by close to 90%, morbidity to AIDS by approximately 90%, and new HIV diagnoses by 2/3 since the mid-90s. Nowhere we have had the success that we have had treating HIV among injection drug users. And the reason for that is that British Columbia has been extremely willing to innovate when it comes to harm reduction programs. Unfortunately, we have not been able to secure the support and the leadership of the federal government when it comes to this issue. But harm reduction is an essential part of the mixture. We need to meet people where they are at, that's been said before. We need to engage them wherever they are, help them to minimize risk activities, whether it's sexual or, in this case, needle sharing and the like. But if we do that, then we are able to incrementally up the ante when it comes to antiretroviral therapy. Antiretroviral therapy works everywhere, but if combined with harm reduction, as you can see here, you can virtually eliminate HIV transmission among injection drug users. We are pretty much on our way. and doing so in British Columbia. Now, the discussion regarding the role of treatment prevention became a lot easier in 2011. Until then, those that were skeptical kept on making the point that our evidence did not meet the ultimate scientific level of scrutiny, which is a randomized controlled trial. So we now have a randomized controlled trial. HPTN 052 was conducted by the NIH, predominantly in Africa and India, largely within serodiscordant HIV heterosexual couples. That is to say, couples made by a man and a woman who were stable couples, where either the man or the woman was HIV positive and the other partner was not. In this study, the couples were assigned to either taking treatment immediately or in a deferred fashion. The treatment was given to the person that was infected in that couple, and what was found is that by accessing ARVs or treatment immediately, the likelihood of HIV transmission was reduced by at least 95%. In fact, if you allow the treatment to take on the few weeks that it takes for people to become virologically suppressed, following that, the treatment was 100% effective in preventing transmission. We now have data that shows that the treatment is equally effective in homosexual couples, so the evidence is all in. Biologically speaking, the treatment can prevent every single form of HIV transmission virtually to 100%. And this is sort of the bad news, if you want. British Columbia used to have the worst epidemic in the country. You see here on the red, BC in the early 90s or mid-90s at the top of the chart, and we are way on our way down. This slide is up to 2011, but the trends continue, and we're very fortunate that we are no longer ahead of the class, so to speak. We are the only jurisdiction that has shown a steady, continued decline in the number of HIV cases per year, thanks to the treatment and prevention program. Saskatchewan hasn't done very well until recently. This slide has not been updated. I've seen the updated slide, and there is encouraging new trends. I am told that the synergies between FNEP and other partners, the provincial government and other such initiatives are really to be credited for the early gains that you have seen. But a lot more work needs to be done. We'd like to celebrate the day that Saskatchewan meets BC as being no longer ahead of the class. And this is important because it's costing lives. People are getting sick, people are getting infected, people are ending up in hospital. The stories that you heard today about people that are go back to the hospital again and again with opportunistic infections should be something of the past. It's no longer acceptable. And not only that, for those that are not so likely to listen to the humanitarian side of this discussion, let me tell you, there is a dollar sign attached to inaction when it comes to combating HIV. And what you see here is estimates of the cost or the benefit of doing or not what I've been discussing. So British Columbia has made an upfront investment on HIV/AIDS. As a result, we are saving ourselves a lot of morbidity and mortality. On the blue line, you see how we are actually saving money. Our government, my Minister of Health, goes around celebrating the success of our program because he's very proud of the fact that we've done the right thing for the persons infected with HIV, for our public health effort, and for our public purse. I often tell him for politics sometimes too, but anyways, the idea here is that this works for everybody. On the other hand, Saskatchewan, until recently, was on a downward spiral. You notice that because of the improvements that I described as of recently, in the last 4 years or so, this trend is beginning to reverse. Again, there is a lot more room for improvement with regards to that. I'm showing you this slide. This is about the cost benefit of the strategy in Africa. not because we're in Africa, but because the behavior of the impact curves, if you want to call it that way, is really the same wherever you go. If you look at your left-hand side chart, what it's illustrating is what happens in terms of lives saved, how many people you are saving by treating earlier and earlier and earlier, going from the baseline to the purple to the yellow to the light blue being what we call the treatment prevention or test and treat approach. You deploy the test and then you offer treatment free of charge immediately. For South Africa, over a 40-year period actually, this would mean saving 5.5 million lives. Cannot afford not doing that. And while it is true on your right-hand side that in the short term you will have to spend a little bit more, notice that the spike in the light blue is quite limited. It's well within a political cycle. And this is critical because this is a benefit that can accrue almost instantaneously. And the spike is over within 4 to 5 years, certainly within 10 years. And after that, we're laughing all the way to the bank. South Africa would be saving in the order of nearly $30 billion by doing this. Not surprisingly, President Zuma from South Africa on September 25th of this year formally committed to endorsing and implementing treatment and prevention in South Africa. Now, moving on to the global discussion, we were very fortunate that Michelle Sidibe, who was appointed the Executive Director of the United Nations AIDS Program, you've seen his picture already, in 2009, he agreed to do a site visit in Vancouver, British Columbia, during the winter holiday, the Winter Olympics in 2010. So he came to visit us in February, and at the same time that he was in Vancouver, he made up his mind that treatment and prevention was going to become the new cornerstone of the United Nations AIDS plan to defeat AIDS globally. He announced that, and we started to work together on this plan. In the meantime, we started lobbying the White House, and ultimately President Obama went on to endorsing the plan in 2011. And of course, President Clinton continued to be one of our chief ambassadors globally. I should mention that Stephen Lewis, a very dear friend of ours, has also been critically influential in opening doors for us globally. Eventually, we managed to go even to the Vatican. We've been everywhere with this. And believe it or not, even the Vatican gets it. So good news there. We are going to be having further conversation with the Vatican next week to discuss this issue. They're making a lot of progress trying to implement the program under the Roman Catholic Church in Tanzania to help them address this issue using treatment and prevention. As I was saying, working with UNAIDS, I've been given the charge, honor, I don't know, both, to help translate this work into a tangible target or new target that help move the fight against HIV and AIDS globally. And so we came together with a large group of colleagues from around the world with this mandate to create a new ambitious treatment target to begin to write the final chapter of the AIDS epidemic. Notice that we say AIDS and we didn't say HIV because we believe that AIDS can be conquered with treatment, or at least pretty close to conquer with treatment. For us to conquer HIV infection globally, we're going to need more research, we're going to need a cure, we're going to need a vaccine, and probably both. The target that we have arrived at, that was, as I said, brought to the United Nations General Assembly and formally endorsed by Ban Ki-moon, the Secretary General, on September 25th, 2014, is called the 90-90-90 target. The 90-90-90 target is calling for us to, by 2020, be able to identify 90% of the people that are living with HIV, to be able to offer them sustainable, high-quality antiretroviral therapy so that 90% of them are on treatment and so that 90% of them achieve full virological suppression. If we achieve the 90-90-90, we are in a position to change the course of the epidemic. Our colleague John Stover was tasked to model the potential impact that the 90-90-90 implementation by 2020 would have over a period of an additional 10 years, up and until 2030. And what you can see here is that in the absence of the 90-90-90, new infections will continue to rise, as shown in the green. With the 90-90-90, we would actually be very well on our way to controlling the epidemic, both in terms of new infections on the left and AIDS death on the right. So the 90-90-90 really represents the new way forward. The United States have formally endorsed it. South Africa has endorsed it. Brazil, Panama, Sierra Leone, a number of countries. Of course, China actually was among the first to endorse it. So we have an opportunity to rally behind this cause and ensure that the 90-90-90 becomes the new global goal, and then together we can see a day where AIDS is actually no more. The economist has been very supportive of all of these, of all people, because they get it. This is good for society, this is good for the economy, this is good for GDP, this is good for productivity. So we need to urge our federal government to formally endorse the 90-90-90. Is the only way to deliver on the promise of antiretroviral therapy. The answer to this question is yes, but we will not have an AIDS-free generation if we don't rapidly and efficiently move to both embrace and implement the 90-90-90. Many thanks.